And then I'll share my screen. What I have a challenge here. I have two screens. I'm gonna stop sharing. Is it possible just to do? Great. Just sharing this one. Can y'all see my screen now?
It's just loading in.
Not yet.
No.
Oh, I think I ran into a problem then because
It's loading. I'll put it on
well,
screen.
you can see everyone,
But
but then I cannot
can
see the rest of it.
It's not on presenter view though.
You can see it.
Or it's not presenter view, but slide show.
It's not. It is in presenter view. Oh, great. It says stop sharing. I think this is not really working well. I don't know why I cannot share my screen. So Victoria, you're going to be here during the session?
Yeah, I'm online.
And so do you mind if I just send the slides to you? Why don't I just send the slides to you and then you can share the screen?
Sure.
Do you mind doing that? Because, thank you. So which email should I use?
You can just use my email. Yeah.
Okay, it's not working because it may be too large. What I'm going to do is to drop this in the box. Great. Now my computer is frozen.
Another option, Cindy, is I can also share my screen to share.
Maybe I'll start it.
If that's an option.
If Victoria could allow you to do that. Apologize, my computer part is frozen right now. Okay, that's fine.
Shall I try it to share my screen?
Sure, we can start off by.
Just if you give me a second. Okay. You could do that. Meanwhile, I'm going to put this in our box to see whether that works. Right, we'll go through this just fine.
Can you see my title slides, Cindy?
Yes, we can see yours. Thank you. All right, so let me just give an opening. Oh, we cannot see it.
Put everyone on screen. We'll switch over after to the screen share.
Okay. So I just emailed it to you, Victoria, on the slides.
Oh.
Thank you. Now we can get started at least. And I think I could do a welcoming session and then to introduce our speakers, and we'll go from there. All right. Well, thanks so much, Juan. Thank you so much, everyone. I apologize for the technology challenges we just experienced. Regardless, we're going to have a fabulous session. We have a fabulous a panel here, and we have a very, very interesting, many interesting topics, all on the theme of the impact of knowledge brokering to policy list to policy. So I am Cindy Kai. The co-chair of Knowledge Translation and Implementation Coordinating Group at Campbell Collaboration. And so since my background is knowledge translation, I'm super thrilled to have a fabulous panel to present on this topic. And first, I'd like to thank the sponsors of What Works Global Summit this year. We have Pan America, health organization and evidence-based medicine center, Lanzhou University, China, and Canada's Drug and Health Technology Agency. We have 6 presenters, and we're going to follow the presentation order as shown in your program. So Hans is going to help us kick off this session.
Okay, thanks, Cindy. Thanks for the introduction and thanks for joining. My name is Ahmad Firas Remoortel. I'm a researcher working for the Belgian Red Cross. And at the Belgian Red Cross, we attempt to scientifically underpin all our activities. And one of the important social activities that we have is the so-called Bridging the Gap project, where we try to make the bridge between school, family, and the direct living environment of a child. In this project, we aim to support the most vulnerable children in their school setting, and we focus on preschool and primary schools. And we try with our volunteers to improve school performance, self-confidence, the social skills, and the school well-being of the children. And emphasis in this project is on the individual attention and the positive encouragement. This project is currently ongoing in more than 70 local departments in Flanders, which is a very specific small part of Belgium, where more than 600 volunteers are actively involved on a weekly basis to provide this support. And we now try to implement the same project in our capital, in Brussels, and that's planned for 2022 until 2025. Now, the central research question to scientifically underpin this project was the following question: which activities, didactical activities, supervised or carried out by a non-professional adult are feasible and effective to improve knowledge, skills, attitude, behavior, and or well-being of socially vulnerable children in a Brussels school context. Now, to apply or to scientifically underpin this project, we applied the 3 principles of evidence-based practice to this project, which means in the first place, we identified scientific evidence. We conducted 17 evidence summaries to investigate the effectiveness of 17 didactical activities. Therefore, we developed search strategies in different databases. We screened a substantial amount of records, and we finally included 81 papers around this effectiveness of these activities, which were a mix of systematic reviews. Most predominantly were the RCTs, non-RCTs, and a few observational studies, 3 cohort studies. Now, in addition to the scientific evidence, the second pillar of evidence-based practice is the preferences and values of the target group, which is in this case the Bridging the Gap volunteers and the vulnerable school children. Therefore, and this group was represented by our social service department, which were actively involved in setting up this research question and defining the 17 activities that were the most relevant to guide these children. And they were also involved in writing a first draft of the guideline manual, and also eventually the final manual. And of course, to translate the evidence, taking into account the preferences and values of the target group, to recommendations, we used an expert panel, which was a mixture of academic researchers, a decision maker, a coordinator of a primary school, some volunteers, and some representatives of our social service department as well. And so they translated during 2 consensus conference meetings the evidence into evidence-based and practical usable recommendations. Now, to give you a very short view on how we formulated these recommendations, we used a decision tree, which you can see on the left side here on the slide, where different items needed to be fulfilled before we were able to recommend a specific activity. And these were scientific evidence must be consistent and in favor of an activity. The activity must be extrapolatable to volunteers, feasible and important for the target group. And then the last part was whether there were some conditions that needed to be taken into account or not. And as you can see on the right panel here, finally 11 specific recommendations were made on 11 different activities, which are listed here. For example, making patterns with toy blocks, reading a book, computer-assisted instruction, and so on. And so now the next steps are to implement this project. So we have a manual, we have a guideline, which is evidence-based, and we are now recruiting at this moment, recruiting new volunteers to implement this project in Brussels. After the recruitment, a training will be conducted, which will be consisting of a standard module, an e-learning, together with an online or classical module. And then finally, we will implement the project by 2025 in 10 pre and primary schools in Brussels. And importantly, we will also monitor and evaluate the impact of this project on different outcomes, primarily school performance, self-confidence, and so I would like to thank finally the entire guideline panel, my colleagues from the Belgian Red Cross and the other guideline panelists. And if you want to have more information, we have one publication available where you can find more details. If you are interested to contact our center, we have different, we have a website and social media as well. So more information can be found there. Thank you. Can you still hear me? I hope so.
Cindy, I don't think we can hear you.
Okay.
Oh, can you hear me now? Can you hear me?
Yes.
Okay, great. I apologize. I just want to thank Hans for this wonderful presentation and very interesting and fascinating. I encourage the attendees to share their thoughts and their questions, comments in the chat box. So I just wonder whether anyone wants to have any question for Hans. All right, here none, I have one. and so my question is that what are the qualification skills that volunteers need to have, because that they would be serving a multilingual, multicultural student from different area? Do they have a specific linguistic or cultural experiences, or is this part of the guidelines for them to acquire skills?
Yeah, that's a really good question, and also a challenge. We are facing this challenge in the recruitment, because we are aware that Brussels is a very complex, well, any capital, I think, with a multilinguistic, multicultural context. So of course, the language is very important. Although we found some evidence also that using the native language of a child as much as possible is also important. But we try as much as possible to match, well, in terms of language, for example, to match, let's say, the possibilities of the volunteer to the school and the children that they will that they will guide. That's for sure. But actually, the profile is very general. In the recruitment itself.
Okay, great. Thanks so much. Well, we're going to move on to the next session, which is we're going to turn to Rachael next.
Just wait for my slides to be shared.
Okay, well, you're waiting for your slide, and Hans, actually, we do have a question in the chat box. So if you could kindly respond, that would be great.
Will do.
Okay. So yeah, hi everyone, and thanks for taking the time to come to our session. I'm Rachael Edwards from University College London, and I'll be talking to you today about our work on embedded researchers in public health settings. My co-researchers on this project were Dylan Neal and Claire Stansfield, and we're currently writing up this piece of research that I'm talking about, so we're very welcome of any feedback. And it's also only one project in a multi-component mixed methods study. Okay, next slide, please. So for those of you who aren't familiar with the term embedded researcher, these are essentially research roles with dual affiliations to academia and a policy or practice setting. And their primary purpose is to enhance cultures of evidence use in this policy setting. Basically, the evidence suggests that through being embedded within a host practice team, a researcher can more effectively bridge the research implementation gap through, among other things, building local trust and therefore enhancing local buy-in, as well as translating research or conducting research that is locally relevant. So the specific form that embedded researchers' roles can take is really diverse, and partly because of this diversity, the concept is still quite fuzzy in the literature, and there's no agreed upon definition. And one area where the literature has been relatively quiet is in the detail on how embedded researchers go about enhancing cultures of research in public health settings, particularly during the early stages of their roles. For example, how do they go about becoming embedded in the first place? And this is what we explored with a specific focus on social processes, research outputs, and early outcomes. Okay, next slide, please. For this work, we explored the case study of clinical research network funded research practitioners. So these were embedded researcher roles who were employed across 15 diverse local authority public health settings in England. And their purpose was to facilitate and enhance research engagement and activity. And we conducted 17 in-depth semi-structured interviews with these research practitioners, as well as a diary study to attain a more detailed picture of their day-to-day activities. And next slide, please. So in terms of the social processes that were important during the early phases of these roles, we found that the first several months of the roles revolved around this process of building trusted local networks. And there were several factors that enhanced this process. So first, introductions and endorsements from colleagues, most often managers, could establish a certain initial level of trust and help ensure that the embedded researchers got access to meetings and individuals who could help them in their roles. Face-to-face contact was also described as being really valuable, and it was actually something that was missing through for a lot of these individuals because many of them started in their posts basically at the beginning of the pandemic. So this is something that's important to consider for employers who are designing hybrid work policies in the future. Another important process was having regular interaction, and that's both formal and informal interaction with colleagues, so that embedded researchers can become an established member of the team and build both professional trust, as well as really get to know their colleagues on a personal level and build that personal trust. It was also essential that the embedded researchers gained an understanding of the local context and demonstrated this understanding to colleagues. What were the barriers and limitations experienced within the local authority, and also what were the local priorities, for example. They also needed to articulate what the purpose of their role was to their colleagues, because this term embedded researcher or research practitioner wasn't very familiar. And finally, embedded researchers described the value of support networks, often because they were the only individuals in their roles. Okay, next slide, please. The research practitioners also delivered several categories of research outputs. And the most prominent of these categories was facilitating research connections. So for example, they often advertised research opportunities and connected academic colleagues to relevant colleagues in the local authority. They also frequently advised and supported research and applied for research funding for the local authority. Now, there was actually confusion about whether they should themselves be conducting research, and for most, this wasn't actually a dominant part of their role. And this is something that's up for debate within the literature, as authors have placed varying degrees of emphasis on different aspects of embedded researcher roles, such as conducting research in practice settings versus building research capacity. Embedded researchers perceived that there had been two primary early outcomes that resulted from their roles. First, they reported that the profile of research had improved in the local authority, and this was evidenced through the fact that they received an increasing number of research queries from their local authority colleagues. And they also observed an increase in involvement with research among their local authority colleagues. But despite these outcomes, they also emphasize that changing a research culture is, as you can imagine, a really long-term and incremental process. It's evolution, not revolution, as one RP put it. And this needs to be taken into account by funders so these roles can receive sustained investment. Okay, thank you. Please, connect with us on Twitter, send us an email. We love to hear from you, and thank you for listening.
Thank you so much, Rachel and colleagues, for this fabulous presentation. It's so fascinating, and we have had a tremendous challenge in, over here in the United States as well, to really make sure that policymakers understand research and also that to implement the research as well. So I find this is super fascinating, that this is a wonderful model to follow. Want to see whether the audience may have any questions for Rachel. Okay. If not, I have one as well for this presentation. So what level of authority do the research practitioners typically have in the sample study? Are they more of a medium level, or they're like in the United States, some of the researchers like, Fauci been appointed as a very super level of the government with the CDC. And so I'm just curious, the level of authority of these practitioners, the research practitioners may have.
Yeah, so in our sample, the level of authority really varied across the research practitioners. So some of them were simply a junior member of the public health team, whereas others were working directly with directors of public health. And that was actually something that was discussed for those who were more junior. It was discussed as a barrier to having impact in their role because they didn't have access to those higher levels within the local authority. So yeah, that's the level at which the research practitioner is placed certainly can have implications for the outcomes of the intervention. Awesome,
thank you. We do have a question from the audience, and this is from Kate, and she said a really interesting. Yes, I find that too. Can you explain how you selected the organizations where the embedded researchers were deployed?
Yeah, so we didn't actually select them. This was a program funded by the Clinical Research Network. So the different local authorities applied to the Clinical Research Network to receive the funding. So that also has implications for the scheme because they had to apply for it. That indicates a certain level of appetite for research already within the local authority.
Great. Well, thanks so much. All right, we're going to move on to the next one. Thank you, Rachel. We're going to turn it to Josephine now.
Thank you so much, Cindy, and the presenters who have been on the floor before. Mine is to bring the perspectives from the settings of Parliament. And I'm very excited about this topic generally because as knowledge brokers, we need to know where we need to make our impact. We need to know where the missing links and how to strengthen those missing links. So my presentation is focused on a PhD study that is ongoing. I'm actually in Cape Town. So this is my PhD research. I'm also a staff of the Parliament of Uganda. We can move to the next slide. And my research is looking at drivers and constraints to evidence use. I'm looking at what are the sources of evidence in that first box. I don't know if it is the text that jumped off, but in the previous slide, the first box there is supposed to have the sources and the sources of evidence, and then the second box looks at the drivers, the third box looks at the constraints, and then the fourth one.
Josephine, you're still there?
And then the circle in the middle should be the one talking about evidence used in Parliament. Can you still hear me? Okay, I think I'm back. So in terms of how
Parliament is set up, my research looked at the perspectives of both the members of Parliament as the main users of evidence, but also the staff of Parliament because they're the generators. So I thought you can't talk about the extreme end without looking at the process of generation. So my key findings based on my question, the question number one, are the main types and sources of evidence for use. So there are three core sources of evidence that I documented: research-based evidence, practice-based evidence, and then communal. And when you look at these three, the members of Parliament seem to prefer mostly citizen knowledge or citizen-based evidence because it is direct and the members are interacting with committees of Parliament on a rather simple basis. It's a one-on-one compared to research-based evidence that is mainly scientific and academic in nature, and so sometimes not easily digestible. In terms of sources, we have internal sources which are derived from within the systems of Parliament, and external sources. And internal sources seem to have more preference because in terms of context, the internal sources need to understand what members of Parliament need more than what we get from outside. Many times the information from outside is not very well focused. It's sometimes very bulky and sometimes outdated. So members of Parliament seem to look more into the internal sources of evidence provided by departments of Parliament and then committees and sometimes the plenary debates and benchmarking exchanges that they undertake. My next finding on the next question is on the what drives evidence. And there are three core areas again that I look at, and these are first of all split on the side of institutional level and then individual level of drivers of evidence. On the side of the institution, debate-based factors are one of the areas that I'm looking at. And then discursive or what we call cognitive factors, the ability to interpret this evidence. And then proximate or agency-oriented factors, the environment through which the evidence is actually generated. And so the nature of role and then framework, these are areas that influence how members of Parliament seek evidence. The oversight role, for example, is one of those that requires a lot of debate and inquisitive approach to what the executive is delivering on. So it is one of those that attracts much more interest of seeking evidence. In terms of discursive evidence, I'll talk about the nature of evidence, the relevance, and then availability. When evidence is more available, then the possibility of using it is also higher. And then in terms of also quality, context sensitivity, but I've also seen that when media picks up an interest, like for example in the committee, then members of parliament will have more interest to read around that area and be able to debate. On the side of individual factors, we're looking at skills, competences, and attitudes. These are great influences towards evidence use. And so as knowledge brokers, these are areas that we need to look at as we promote evidence use in parliament. Next, please. In terms of the constraints, we have a number of constraints that range from time constraints. Sometimes accessing evidence is a challenge for members of parliament. They have restricted calendars and timetables and agendas that need quick action. Weak systems and processes also interfere with this process of them trying to use the evidence. When evidence comes, when it is poorly packaged and presented very badly with high terminologies, it becomes hard to use. And also sometimes when the information is highly overloaded, also it is hard. But also more important for us to talk about here is the political constraints, that sometimes evidence can be available, but the environment, the political environment is not favoring the use of this evidence, especially when I talk about South Africa, where there's a lot of whipping and controlled by parties, because parties are the ones that nominate members to parliament on how much you can come and speak against maybe one of the members of the executive, like the minister, so it constrains use. Again, our constraints also appear in skills, competencies, and attitudes. If they are negative, then they again affect constraints. I mean, they affect evidence use. And my last one, the last finding on my fourth question is how to strengthen. So in the next slide, I'm looking at how to strengthen. These are many, but I'm just going to draw on the side which is bolded. Improving the climate of evidence use in terms of safeguarding neutrality, setting rules that allow members to use evidence, and then facilitating freedom to act, trying to minimize the political factors that interfere with evidence. Prioritizing and co-producing, it means working together with members of parliament and making them to own the processes of evidence. Packaging and better pushing through of the evidence, making the evidence more accessible, using multiple sources and making communication of this evidence more friendly. Facilitating pool is to make the evidence available, for example, setting up one-stop centers so that members of parliament can know where to access evidence. But more important, also engaging with decision makers in terms of networking and collaboration with academia, but also media and civil society organization. So my last slide is just about generally what are the lessons that we can talk about here. That evidence use in parliament is unquestionable. It does not occur in obscurity. There are a lot of interplays that we need to talk about to consider at individual, organization, and macro levels. More effective use of evidence can promote its use in decision making and the dynamics therein. And so every intervention that we are making for us as knowledge brokers should be towards enhancing opportunities for evidence use for wider system changes. Thank you so much.
Terrific. Well, thanks so much for your presentation. I want to turn to the audience to see whether they have any questions. And so while waiting for them, I do have one question, very quick one. So whether, do you see any differences in terms of using evidence among different sectors of the government? For example, education, transportation, Department of Health, Human Services, or they're the same?
They're not the same. I see health has much more, because I think of the historical factors with health research. So there's much more availability of health research for use more than other sectors that we have in parliament. So I would say health takes the lead.
Terrific. Thanks so much. So Josephine,
Yes,
there's another question in the chat box. So do you mind if you go in there and answer that question in the interest of time? Okay.
Okay.
Let
me answer that. Thank you so much.
Perfect. We're going to turn to our next speaker, Edward, who's going to present next. Right.
Okay, so thank you very much. My name is Kayongo Edward. and I work at the Center for Rapid Evidence Synthesis as a research scientist in Uganda, based at Makerere University. So my presentation today is really short, and I'm here to discuss about the easy-to-read evidence profile, provide evidence in a policy dialogue. So basically, a background to this is that many times when we go through several policy processes, we usually want to engage policymakers in form of a policy dialogue. This could be probably deliberative dialogue, a dialogue just to bring an issue to the attention of the policymakers in whatever formal case you want to hold this policy dialogue. So leading to this policy dialogue, there are several things that go on in the background. You're going to produce the evidence, you're going to engage citizens in form of citizen panels, compile all this evidence together, and submit it to the policymakers in preparation for the policy dialogue. The expectation is that the policymakers are going to read that information, leading to the policy dialogue, so that the deliberation or discussion is informed by the best quality and quantity of evidence out there. Unfortunately, many times we've observed that the policymakers end up coming for the policy dialogue without reading the evidence that we've provided. This could be because their schedules are really packed, so they are so busy. They really don't have the time to read the evidence you're providing, or the evidence is not really a priority to them. So they would rather do other things leading to the policy dialogue rather than interact with the evidence that you've given to them. Or the other issue might be the way we package the evidence. You're giving a policymaker a policy brief, a rapid response brief of 6, 7, 10 pages. Policy briefs can even go up to 30, 50 pages. Citizen panel reports could range from like 5 to 10 pages, whichever the case. So it could be the bulkiness of the information that we are providing that could affect the policymakers' interaction with this evidence. So we decided to develop and pilot an easy-to-read evidence profile that would combine the evidence in such a manner that the policymaker can interact with this evidence within 15 minutes or even less, leading to the policy dialogue. And this, the main objective of the easy to read is to ensure that the policymakers read the evidence leading into the policy dialogue, but also stimulate their interest for them to want to interact with the bigger reports or the bigger evidence products that you would have sent to them leading to the policy dialogue. So it is really a two-way thing to this kind of work that we did. So essentially what we did was we drew inspiration from conferences where you attend a conference and the people who are generating real-time summaries of the discussions that are going on. Typically, they points that they keep screening out there. So even if someone comes on late for a particular session, when they read these summaries, they easily get to speed with what has been happening during a particular session. So these really graphic, a little bit playful, a bit of cartoons here and there, using different colors to stimulate interest in reading and to stress particular kind of points. And they are really engaging. So we decided to go out and do a similar thing to that, bring all this evidence together, summarize it in such an engaging manner, but also very easy to read. For example, the methods summarized in like half a page, but not really words, but more of cartoons and processes, presenting the processes that have led to the final policy dialogue where we would be at a point. Even the evidence presented more in bullet points, key messages being put out there, and where you could convert a particular set of points into a graphic. You go ahead and do that so that it is very easy for the policymaker to interact with this kind of information. So we used this particular easy-to-read product on a topic of COVID-19 vaccine hesitancy in Uganda. We had a question coming in from the Ministry of Health where they were trying to address the challenge of COVID-19 vaccine hesitancy. Just as Josephine has just said, in Uganda, health really leads the way in the use of evidence in informing policies and decisions. And we also engage within the health space at the ministry. So we looked at the evidence, developed a rapid response brief. We engaged citizens in form of citizen panels. We held a series of 4 citizen panels to try and understand the context of vaccine hesitancy, then share evidence about the different measures that can be used to address vaccine hesitance and get the citizen input into those different measures, then get all that information, compile it together and give it to the policymakers at the Ministry of Health and civil society. And then we also invited media representatives to talk about how to address COVID-19 vaccine hesitancy. So we use the easy-to-read products. And interesting enough, all the people we invited for the policy dialogue, they actually read the easy-to-read document that we submitted. And the discussion was heavily informed by the evidence that we had put together, unlike several of the other policy dialogues which we had where the discussions are not fully informed by the evidence. And the easy-to-read policy documents actually stimulated the individuals, the policymakers we invited, and the people from civil society to actually interact with the other documents that we had attached along with the easy-to-read. So we had almost everyone read at least one additional document that we had attached, and then we had one individual who read all the 5 documents that we had attached as part of the preparations for the policy dialogue. So in conclusion, from that exercise, we drew that the easy-to-read evidence products can actually solve the challenge of policymakers not engaging with the evidence, leading to the engagement through the policy dialogue. However, there is still a need to heavily assess the level of delivery of the information in this manner, and also assess whether the interpretation of the evidence that we would have delivered to the policymakers in this manner would still be the same compared to someone who has actually interacted with the bigger documents. That is essentially what we did, and thank you, everyone. Questions are welcome. You can kindly reach me specifically through those emails that are on the screen. Thank you.
So time, we're running a little behind. This is from Fiona Kimball. A very interesting. Thank you. Many of these findings resonate with barriers to evidence use in the UK. Is there anything either in the barriers to solution? Oh, this is for Josephine, or let me ask a question. Let me ask this question from attendees. Anything that from the audience? Any question you all have? Okay, so I encourage the presenters to take a look at their the chat box to address the questions. And so there's one question from Fiona Campbell. Is there anything either in the barriers or solutions that you feel unique about the context you have expertise in? I think this one, Fiona, this one address, do you want to ask Ed about this, or Josephine? I'll give you a chance to do this. Okay, I have not heard back from her, so I would encourage the presenters to go in there to check that question out. So thanks so much, Ed, for your presentation. Now we're going to go to turn it to Ahmad Firas.
Hi, everybody. It's so nice to be gathered here together. Hopefully next time face-to-face, so we get to interact more in person. My work is about decision makers' experiences with rapid evidence summaries to support real-time, evidence-informed decision-making in crises. So all that is that we wanted to figure out, what do decision makers who work in health and humanitarian emergencies need in terms of evidence support to help them inform their decision and practice? You're probably wondering why that is important. Well, in humanitarian practice, and especially in crises, time is of the essence. Decision makers need evidence support in real time in order to improve the effectiveness and efficiency of interventions, but also to make sure that the funds that are being donated to organizations are well spent and that it is spent in the most appropriate space. Next slide, please. So I want you to all think about the last time you had to make a decision How hard was it for you to make that decision, and where did you go for that evidence support? Our study was really looking at the overall landscape of health and humanitarian emergencies. We wanted to interview decision makers who worked in health and humanitarian emergencies across the world, and we wanted to do surveys and semi-structured interviews to figure out from them what are some of the preferences they had for evidence support, what are some of the challenges they were facing, how can we best support their evidence needs in the form of an evidence summary. Next slide, please. So what we actually ended up finding after interviewing 26 of those decision makers is that in situations where time and resources are limited, which is often is the case in any health and humanitarian emergencies, think of typhoons, floods, COVID-19 pandemic, evidence summaries really take precedence in informing the decision making. And that's not surprising to a certain extent. What we did find to be surprising is that the evidence summaries were not actually used or systematically implemented across organizations where there is a need for real-time evidence support. So evidence summaries are short summaries, and the key aspect here is key actionable messages. They really highlighted the idea of bullet point checkpoints, infographics being strongly preferred as a way to visually look at the evidence and be able to use it and comprehend it in real time. We also found that decision makers prefer curated information sources. So they really wanted trusted sources where they can retrieve that evidence. They didn't want to have to look for it themselves. They wanted to rely on people like in-house technical advisor and colleagues to be able to access that evidence. And they found that summaries that demonstrate a critical appraisal of the evidence, they wanted to make sure that there is some kind of quality appraisal of the evidence itself so they can trust the evidence that's being presented to them, really increased its use in crises. Next slide, please. So I want to show you just two examples. On the far left, I appreciate that it's small. Feel free to reach out to me and I'll give you a bigger version of those. Is that the evidence summary template that we were able to create based on our summary findings. And the exciting thing is that the Canadian Red Cross, where I'm currently working, we are able now for the past 5 months and continuing to do so, implement this evidence summary in actual real crises. So the two examples on the right, you'll see us implementing our evidence summaries into COVID-19 filtration devices and the COVID-19 vaccine, where we had questions given to us by decision makers who are working in the field, trying to figure out what is the best vaccine, how many booster shots do we need for our staff? And the second evidence summary request that came in was about filtration devices to prevent particle dissemination of COVID-19. We've also now been able to produce 26 evidence summaries to date and looking at increasing the evidence summary use across different Red Cross movements in the world. Next slide, please. Finally, we wanted to put forward ways that we can inspire others who work on synthesizing evidence summaries of how recommendations, how they can improve it. So writing summaries in a clear, succinct, and action-oriented format. Really think about this actionable checklist and infographics being a very much an important aspect of how we produce evidence. Identifying the target audience, who is the summary written for and why it is important for that audience. Highlighting the most up-to-date evidence. People really wanted to know how up-to-date this evidence is and how they can rely on it. We saw this a lot during COVID-19 with the changing evidence on face masks and their effectiveness and importance. We also saw the idea of presenting the contents of evidence summaries in more different formats. So we're looking now at audio podcasts, videos, elevator pitches, video scribe, different knowledge translation mechanisms to disseminate the findings of evidence summaries. And finally, this really important key concept about organizational stewardship, having senior leadership in organizations support the synthesis of evidence summaries and ensuring that people have the dedicated time to read them and use them in decision making. I believe that is my last slide, but I just want to check. Yeah. And for implementations for practice, we're really looking about ways how to develop workshops, training workshops across all organizations that can be geared at helping researchers think carefully about how to write evidence summaries. And we are currently in this process right now where we're disseminating our training workshops to different organizations. I want to appreciate and thank you all, and Cindy especially, for hosting this platform and for the questions. And please reach out to me anytime you have any questions or want to work together on how to best support evidence-informed practice in health and humanitarian emergencies. Cindy, back to you, and thank you so much.
Well, thank you so much. Appreciate this wonderful presentation. It's so timely as well, especially COVID is still here. So I'm turning to the audience to see whether y'all have any questions for Ahmad Firas. And if not, I do have a question prepared.
Sure.
When I read your presentation, and so my question, my curiosity is just how the organizations were selected for your sample.
So we picked, actually, we focused more on the individuals. So we categorized the decision makers into 5 types: senior decision makers who worked in health and humanitarian emergency in the last 10 years, field managers, healthcare providers, analysts, and then researchers and policy. So we really were focusing more on diverse types of decision makers that work across organizations. We didn't want to just focus on one type of organization. But that's a great question.
That's great. We love that diversity. I encourage all the participants to continue to shoot your questions in the live Q&A session, and also encourage the presenters to take a look at the questions. I see 2 questions for Ed, and then perhaps one question, another. Yeah, there are more questions there. I see 2 for Edward. So
I also see there's a question from Kate, Cindy, for me. Do you disseminate these evidence summaries produced by for the Canadian Red Cross? At this moment, we're actually limiting it to Canadian Red Cross because we're piloting it, but we are looking at actually extending that. So please do reach out, Kate, because we'd be very interested in working with other organizations to share our platform and our working training workshops for sure.
Terrific. Thank you. Now I can mark that question's addressed. Fun. Awesome. Now we're going to turn to our last presenter, and thanks so much for reading so patiently. I think we got cut up with the time, and so you can take all the 10 minutes left, but still 5 minutes, okay, and 3 minutes question. We still obeyed the rule.
Great.
Okay.
Great. Okay. Well, thanks for staying on to the last session. So I'm Don Neal, and I'm reporting on research that I led with Alison at the EPPI-Centre, with colleagues at the EPPI-Centre, including Bridget, Katie, Sandy and James Thomas, as well as colleagues from the co-production collective, so Lizzie Kane and Nick Hutchinson-Pascal. And this project was really trying to think how we can make evidence from meta-analyses of public health interventions more useful for decision makers. Because when we go out and speak to public health decision makers working in local settings in the UK, we tend to find that they're not able to engage with meta-analysis of public health interventions very frequently. And when we speak to people, it looks like it's very much a problem of context. People are unsure if the evidence travels to their particular context. So this project that I'm reporting from is a project that tried to knit together co-production, the use of logic models with interrogating existing meta-analyses. And we approach things from the perspective of a decision maker. Next slide, please. Great. So we approached meta-analysis from 2 public health intervention reviews. One of those focused on school-based interventions to help improve mental health outcomes, and the forest plot from that particular review is displayed here. And then we also used a review by Langford and colleagues looking at whole school approaches to improve children's health, and we focused in on interventions that help to reduce fat intake. And we approached this, both of these reviews, by asking particular questions that we thought resonated with decision makers, and we developed methods around these particular questions. So the first question we thought a decision maker might have about meta-analysis was, what can you tell me about the impact of context on the outcome? And existing meta-analysis methods were pretty limited in terms of being able to address multiple factors simultaneously and explore those factors on the effectiveness of the intervention. And the second question we thought decision makers might have was one where we thought they may be less interested in the actual precision of the effect and the size of the effect, but just simply, is the study likely to be a good idea for my area or needs? And then taking into account contextual factors in the study to make that decisions. And this the approach we used to address this question was binary logistic regression, and that involved grouping the studies into an effective or ineffective group. And you can see on the forest plot that there is a kind of division between studies that did have an effective result in terms of improving children's mental health in this case, and those that didn't. Next slide, please. So for both approaches, so the enhanced subgroup analysis and the binary logistic regression, we developed a process where we were thinking about the logic model, and we had the logic model as an anchor. We used this to make decisions about what might be important. We then extracted the characteristics of each study, and we then created data matrices for enhanced subgroup analysis and used cluster analysis, to identify groupings of studies based on those characteristics. And in the binary logistic regression process, we classified studies as being effective or ineffective, and then looked at the associations between different contextual factors on the odds of success. Next slide, please. So for the enhanced subgroup analysis, we explored the gender composition, ethnicity, presence of low socioeconomic status, whether the study was conducted in a high or low or middle income country, the characteristics of the healthcare system, and the level of fat intake at baseline, in order to develop groupings of studies. And we identified three groupings of studies. The first group consisted of studies that had high levels of ethnic diversity but no universal healthcare. A second group of 3 studies that had low levels of ethnic diversity but with universal healthcare, and a third group which consisted of just one outlier study with a high gender imbalance. And we did see some impact that the first subgroup did appear to be associated with a larger decrease in fat intake. And the possible interpretation here was that these were mainly US studies, and they may have had larger impacts than some of trials conducted elsewhere because of having differences in health systems and larger pre-existing inequalities. But we also saw that this result didn't produce, or this model didn't produce conclusive results. There was some overlap in the subgroups. And next slide, please. When we applied our thinking and created a binary logistic regression model, we did see more of a conclusive impact here. So we were able to model the probability of being in a successful group and looking at the age characteristics and gender characteristics of participants. And here we saw quite conclusive evidence that we didn't see with conventional subgroup analyses, where the studies involving older participants and with more males were much more likely to be effective. And from the binary logistic regression, we were able to calculate predicted probabilities of a study reporting significant improvement in positive mental health. And we developed a number of caveats and advantages for this approach. And there's a lot of thinking still to do with this approach and the earlier approach as well. But just in the interest of time, I'll move to the next slide and to discuss the conclusions and the discussion. So this is very much work in progress. We're trying to develop approaches that we think are going to lead to more useful evidence for decision makers. And we need to fully evaluate these methods, but we think that these approaches are doing something quite different from current practice and may be useful in addressing decision makers' questions about evidence.
Great. Well, thanks so much, Dylan. This is also a very fascinating presentation. I have a very quick question about whether, how likely would the studies will present the contextual information for you to be able to do this kind of analysis?
That was one of the big challenges. It's one of the big caveats, really, is that there was we had a very complex logic model supporting this work that showed a lot of different contextual impacts. But within the studies, we were we were having to draw on quite limited representations of context within the studies. And also we had to make decisions about how to harmonise different measures. So, for example, socioeconomic status being measured in very different ways, ethnicity being measured in very different ways across the studies, for example. So we had to make decisions about how to code that data and harmonise that data.
Great. Well, thanks so much. Now that concludes our wonderful session. I want to thank the speakers for preparing for their presentations and for presenting, and also you for attending. And so please visit the virtual poster gallery, exhibit, and meeting hub. And also thank you for your patience with the technology glitches. We made it through. And thank you all so much. Have a wonderful rest of the day or evening, no matter where you are. And so good to be with y'all. Thank you.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye.
Bye. Take care. Right. We made it. Thanks so much.